Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen. And in this month's video, I would like to discuss altogether 8 studies which were presented at the European Stroke Organization Congress in Switzerland last month. I would like to start with this never-ending story of lowering increased blood pressure in acute stroke. Whenever someone has a stroke, blood pressure is increased. And stroke physicians for the last 10 years have been obsessed with the concept of lowering blood pressure in acute stroke. Now, the INTERACT-4 study in the New England Journal of Medicine was done in China. This study had more than 2,400 patients with elevated blood pressure and had a stroke. And in this study, the blood pressure lowering or control was done on the way to the hospital. And there was no surprise that there was no benefit. In subgroup analysis, people with ischemic stroke had even a worse outcome, and only people where later on cerebral hemorrhage was diagnosed had a benefit, but this doesn't help because with the exception of mobile stroke units, you don't know whether a patient has ischemia or bleeding. And hopefully, this is now finally the end of lowering blood pressure in acute ischemic stroke. The next study is the TRUE study published in Lancet Neurology. And this is a study which investigated the concept whether it's really necessary to lower blood pressure prior to thrombolysis if the blood pressure is above 185 to 110 millimeters mercury. This was a cluster randomized trial in the Netherlands in patients with acute ischemic stroke and elevated blood pressure. And half of them, the blood pressure was lowered. In the other ones, they waited until the blood pressure came down and then performed thrombolysis. A study with 853 patients, there was no benefit of lowering blood pressure and no increased risk of waiting in terms of bleeding complications. So finally, after 15 years, we have now again no benefit that it makes sense to lower increased blood pressure except for hypertensive crisis in people with ischemic stroke. The TEMPO-2 study published in Lancet investigated thrombolysis with tenecteplase in people with a mild ischemic stroke defined as NIHSS 025 and evidence of intracranial occlusion. This study had 886 patients and was terminated prematurely due to futility. There was no difference in functional outcome, and there was an increased risk of mortality and intracerebral bleedings with tenecteplase. This means we have now 2 kinds of studies, ones with alteplase and the other ones with tenecteplase, which clearly indicate that it doesn't make sense to perform thrombolysis in mild ischemic stroke. The next study is the last trial in the New England Journal of Medicine, and this study investigated again thrombectomy in large strokes. We have clear benefit that thrombectomy is highly effective in moderately sized ischemic strokes, but this study included people with aspect 0 to 5, which are large strokes. And the study had 333 patients, and there was clear benefit of thrombectomy in these large strokes. And now we have altogether 4 trials which showed the benefit of thrombectomy in large ischemic strokes. Now let's move to early secondary prevention. The ATEMIS study published in JAMA Neurologist investigated the combination of clopidogrel and aspirin versus aspirin in people with moderate to severe strokes. We already have clear evidence that this is beneficial in people with high-risk TIA and mild strokes. The study had 3,000 patients, and the primary endpoint was clinical worsening within the first 7 days, and there was a clear benefit of combination therapy versus aspirin monotherapy and no increased risk of bleeding for a treatment period of about 10 days. And this means now that dual antiplatelet therapy is established for the whole range of high-risk TIAs up to moderate to severe strokes. The next study deals with intracerebral bleeding. This was the ANNEXA-I study in the New England Journal of Medicine. This was a study which recruited patients who were treated with factor Xa inhibitors mostly for atrial fibrillation and had an intracerebral bleed. And so were randomized either to andexanet alpha, which is an antidote to factor 10A inhibitors, or standard of care, which usually was prothrombin complex. And the primary endpoint was quite complicated. It was hemostatic efficiency defined by less than 33% increase in the volume of the bleeding and no worsening of the NIH of more than 7 points and no rescue therapy. 260 patients in each group, and there was clearly a benefit of andexanet alpha compared to standard of care. There were more thrombotic events on andexanet alpha with 27 versus 15. And this study shows there is a clear benefit of andexanet alpha in these patients, but there is also a slight increase in thrombotic events. Now, another study with cerebral hemorrhage is the STOP MSU study published in Lancet Neurology. Previous studies showed no benefit of tranexamic acid in people with intracerebral hemorrhage. But now this study is different because it investigated tranexamic acid in the first 2 hours after symptom onset, 202 patients. Unfortunately, no difference in increase in bleeding volume or clinical outcome. And the last study is a switch study published in Lancet. Previous studies showed little benefit of decompressive hemicraniectomy for cerebral hemorrhage, including lobar hemorrhages. Now, this study in Europe investigated decompressive hemicraniectomy versus conservative treatment in people with large basal ganglia hemorrhages, 200 patients, a small benefit, but the clear downside is a high number of patients with permanent severe neurological deficits and disability. And again, this means that the physicians have to discuss very carefully with the relatives of a patient, or if the patient is not aphasic, whether this procedure should really be done. Dear colleagues, exciting results from ESOC 2024 in Switzerland. I'm Christoph Diener from the medical faculty of the University Duisburg-Essen in Germany, and thank you very much for watching and listening.